Good morning, everyone. Today's topic is reactive attachment disorder. Definition: as defined in DSM-5, describing young children who show no consistent evidence of selective attachment behaviors towards an adult caregiver. Instead of approaching adults for comfort and support, they fail to approach and show distress without seeking or responding to the comfort. They rarely engage in socially reciprocal interactions with the adults. Introduction. Attachment is defined as the emotional tone between the children and their caregivers and is evidenced by an infant seeking and clinging to the caregiver person, usually the mother. By the first month, infants usually have begun to show such behavior. It was worked by John Bowlby. Bonding concerns the mother's feelings for her infant. Development of attachment. There are 5 stages. In the newborns, the age group between newborns to 2 months, it is limited discrimination. The ability to discriminate among the caregivers is limited, and the preferences are not observable. Between the 2 to 8 months, the discrimination with limited preference, that is, they clearly discriminate different caregivers, and that there are different patterns of interaction when engaging with the strangers. Between 8 to 12 months, it is focused attachment where there begins the separation protest when stranger appears and infant becomes notably more wary of interacting with the strangers. Between 12 to 20 months is a secure base where independent ambulations ushers in increasing exploratory forays away from the attachment figure, but alternating with the return back to the caregiver. 20 months and beyond, that is goal corrected partnership, that is attachment relationship shifts from nearly complete dependency on the caregiver to one in which the preschooler becomes aware that others including the caregiver have intentions and wishes different from their own. Strange situation procedure. Based on the observations of a young child and parents during the brief separation and reunion, Mary Ainsworth formulated the strange situation procedure, where there are 3 types of attachment: secure, insecure, and disorganized attachment. In secure attachment, the child experiences their caregivers as emotionally available and they are more exploratory and well adjusted. Whereas in insecure attachment, child's perception that caregivers are not available is present. Whereas in disorganized attachment, child results from experiencing both the need for proximity and apprehension in approaching the caregiver. Epidemiology. Very little data exists on the prevalence of reactive attachment disorder. A study of 1646 children aged between 6 to 8 years found that the prevalence of reactive attachment disorder is 1.4%, and about 10% of young children are documented with neglectful and grossly pathological caregiving exhibit reactive attachment disorder. Risk factors include pathogenic care, that is maltreatment, grossly neglectful care, and general psychosocial risk factors include poverty, disrupted families, and mental illness among the caregivers. Etiology. The longer the children live in the conditions of deprivation, the more likely they are to develop an attachment disorder. It is very rare in children adopted before the age of 6 months, whereas children who are deprived after the age of 2 years are more common to develop. Lower IQs and stunted growth may also have attachment disorders because deprivation compromises both the growth and IQ, and it is difficult to know whether these problems precede or are merely additional consequences of deprivation. Genetic polymorphisms are also risk factors for attachment disorders, whereas clear-cut data is not available. And differences in the brain structure and functioning includes reduction in the gray and white matter volumes and reduced electrical activity in higher frequencies and increased electrical activity in the lower frequencies. Caregiver characteristics like severe personality disturbances to psychopathology appear to be important. And parental mental retardation and poor basic parental skills, particularly in context of little social support, may also increase the risk for neglect. And the traumatic experience of prolonged separation from the caregiver in the early childhood is also a risk factor. Diagnostic criteria. DSM diagnostic criteria includes a consistent pattern of inhibited, emotionally withdrawn behavior towards the adult caregivers, manifested by both of the following: that is, the child rarely or minimally seeks comfort when distressed, and the child rarely or minimally responds to comfort when distressed. And the persistent social and emotional disturbance characterized by at least of the following, that is minimal social emotional responsiveness to others, limited positive effect, and episodes of unexplained irritability, sadness, or fearfulness that are evident even during the non-threatening interactions with the adult caregivers. And the child has experienced a pattern of extremes of insufficient care as evidenced by at least one of the following, that is social neglect or deprivation, repeated changes of primary caregivers, and rearing in unusual settings that severely limit opportunities to form selective attachments. The care in the criteria C is presumed to be responsible for the disturbed behaviors in criteria A. And the criteria is not met for autism spectrum disorder. The disturbance is evident before the age of 5 years, and the child has a development age of at least 9 months. Clinical features. They appear to be withdrawn and unresponsive. They may show distress with no anticipation of comforting, and they fail to initiate and respond to social interactions. And emotional regulation abnormalities include reduced or absent expression of positive emotions, unexplained display of irritability, sadness, or anxiety. What is psychosocial dwarfism? It manifests between the age of 2 to 3 years, and usually short stature and frequent growth hormone abnormalities along with severe behavioral disturbances are seen, and can result from inimical caregiver child relationship, and inability to obey rules, lack of guilt, and need for attention or affection is also present. Comorbidities of reactive attachment disorder include cognitive delays, language delays, stereotypies, medical conditions like severe malnutrition, depressive symptoms, or anxiety disorder. Assessment. Child behavior checklist can be used along with the behavior assessment scale for children, random attachment disorder questionnaire, child and adolescent functional assessment, and child attachment and relational trauma. Differential diagnosis includes depressive disorder. Here, children are ought to turn towards caregivers for comfort in depressive disorder, whereas it is not present in reactive attachment disorder. In autism spectrum disorder, language skills are delayed, but in RAD, language skills are delayed, but there are no stereotypies, whereas stereotypies are present in autism spectrum disorder. Intellectual disability, it is mild compared to ID with other disorders. Attention deficit hyperactivity. Course and prognosis. Children who are placed into families typically do not show signs of RAD on follow-up of 1 year, and the prognosis is influenced by the duration and severity of the neglect and degree of impairment initially. And the good prognostic factor is the stable caregiving environment. Management. The first consideration is the child safety, and early involvement of child protective services is also warranted, and assessment of parental fitness is also important. And clinician may play a crucial role in staying involved with the child who is in the foster care. And once the child is in safe placement, full attention can be paid to the psychosocial intervention. The primary goal is to provide a primary attachment figure. What is secure attachment? Responding sensitively and value the child as an individual and place the needs of the child ahead of their own provides a secure attachment to the child. And parents are advised to limit unnecessary contact with adults outside the family for several months if possible, and reduce child or adult barriers to attachment. That include child barriers include aggressive and oppositional behavior, emotional dysregulation or withdrawal. And adult barriers include lack of psychological commitment with the child and problematic relationship history. Psychosocial interventions for families in which child has reactive attachment disorder include psychosocial support services, including hiring a homemaker, improving the physical condition of the apartment, or obtaining more adequate housing, and improving the family's financial status and decreasing the family's isolation. And psychotherapeutic interventions include individual psychotherapy, psychotropic medications, and family or marital therapy. And educational counseling services include mother infant or mother toddler groups, and teaching parenting skills. Provision for close monitoring of the progression of the parent's emotional and physical well-being. And hospitalization is necessary for children with malnourishment, and if neglect or emotional, which may be emotional, physical, or sexual abuse is suspected, it should be legally reported to the appropriate law enforcement, and child protective services should be involved. The three basic psychotherapeutic modalities include: first one is to promote positive interaction with the child, and it can be practiced by using the techniques of positive reinforcement, and better results come from working with both the caregiver as well as the child at the same time to get emotionally meaningful exchanges. Attachment and behavioral catch-up. To decrease frightening behavior towards the infant by the parents, and it is to increase sensitive and nurturing interactions between the parents and the infant, and the intervention was manualized so that the parents were specifically guided in how to provide those interactions with their infants. Attachment specific treatments include circle of security, where parents are psychoeducated, and along with that psychotherapy is provided, or attachment and behavioral catch-up is involved in this, and the review is based on the videotape parent and child interactions here. Caregiver child didactic therapy is attachment informed rather than attachment deprived, and such as child parent psychotherapies are involved here. And the symptoms of the disorder disappear with the placement in a family that can provide a positive caregiving environment. Thank you.